Good evening, everyone. Welcome to our National Keratoconus Foundation evening webinar. The topic of tonight is addressing keratoconus vision needs throughout life. And boy, are you all in for an amazing treat tonight. We have three very distinguished experts in the field of keratoconus tonight, each speaking. I'm going to give a brief bio of each of them because if I were to read all their accomplishments, it would take the entire hour. So I'm going to start with Dr. Peter Hersh, who graduated from Princeton University, received his medical degree from Johns Hopkins Medical School, did his ophthalmology residency at Harvard Medical School, and received additional training in cornea surgery as a fellow at Harvard, where he remained on faculty for several years. In 1995, Dr. Hersh founded the Cornea and Laser Eye Institute, Hersh Vision Group, and the CLEI Center for Keratoconus. He does a lot of education and teaching with various universities and was even the author of the research study leading to the first FDA-approved laser vision correction in the United States. Importantly, regarding keratoconus, he was a monitor and author of the clinical studies of corneal crosslinking, which eventually led to the FDA approval in 2016 for the treatment of keratoconus and corneal ectasia. Our second doctor here is Dr. Stephen Greenstein. He's an ophthalmologist and the medical director and director of Cornea and Refractive Surgery at the contact lens, the CLEI. Following in Dr. Hersh's footsteps, he's a graduate of Harvard's Cornea Refractive and External Disease and has completed a Cornea and Refractive Fellowship at Mass Eye and Ear. Let's go on and see what you need to know here. Again, so many accomplishments. He's worked closely with Dr. Hersh and the CLEI Center for Keratoconus in the research department. He completed a one-year pre-residency fellowship where he concentrated his research on keratoconus and cross-linking. He's had numerous publications and presentations at scientific meetings and written many books and chapters, including in Cornea, Fundamentals, Diagnosis, and Management, one of the primary references for cornea surgeons around the world. And last but not least, we have our optometrist, Dr. John Gelles, the Director of Specialty Contact Lens Division at the Cornea and Laser Eye Center in New Jersey. He's a specialty contact lens provider and a board member of the Contact Lens Society of America, an executive board member of the International Keratoconus Academy, and an advisory board member for the Gas Permeable Lens Institute. He lectures frequently around the world and has authored several medical journals and professional publications, does a lot of teaching with students, ophthalmology residents, and what a treat it is to have the three of them here today. A little bit of housekeeping. We will be taking questions from the audience. You can go ahead and type those into the chat. The last 15 minutes of our session today will be answering any questions that you have. We'll try to get to as many as we can. And last, I'll just say that I am Gloria Chu, optometrist. I practice at the USC Roski Eye Institute in Los Angeles, California. This is going to be my last time moderating for the National Keratoconus Foundation. It's been 2 years, and so your next webinar in 2 months, our new moderator, Dr. Karen Lee, will be taking over. So without further ado, I am going to turn it over to Dr. Peter Hersh. Take it away.
Gloria, thank you so much, and thank you and the National Keratoconus Foundation for having us here tonight. Participating with the foundation over the years has always been extraordinarily rewarding for us, and the educational programs that you put out are just amongst the best in keratoconus in the world. What our group wanted to discuss tonight are addressing keratoconus visual needs throughout your life, because things change as you get older. But let's just step back for a second and give a little background on keratoconus. Keratoconus is a somewhat unique condition because It results from the lack of biomechanical strength in the cornea. You can think of it much like a thin spot in a tire or a balloon, where you start to get a bulge in that thinner area that progressively increases over time. The normal corneal thickness is 540 microns, very, very thin, and the keratoconic cornea can thin even more. And when it does this, one can get a progressive bulging and steepening, which you can see on the topography on the upper right. Red is high, blue is low, and green is in between. So the red area is the area of keratoconic bulging that you're seeing. Now, the problem with this, if we go back a moment, is that the irregular shape scatters light. With a normal cornea, which is like the lens on your watch or on your camera, the optics are nice and smooth and they focus light into one place. It's like a high definition television. In keratoconus, light through different areas of the cornea are focused in different places. So you can think of this as being static on your television. Indeed, we call it visual static. And this visual static decreases your general visual function, and that's what leads to loss of vision in keratoconus. The normal cornea, you can see here, is comprised of what we call lamellae or pancakes of collagen, and they are a number about 250, and they make the cornea strong. They make the cornea a clear lens, and they supply the superstructure of the cornea. What you see in the middle here is a cross section of those beams, and those are linked together by what we call collagen crosslinks to keep the cornea nice and strong. In keratoconus, however, those bands of collagen are weaker than normal. So it's like having not enough wires on a bridge and the bridge becomes floppy. Well, similarly, what you see here is the keratoconic cornea below, which is much floppier, as you see, than the normal cornea above. And this is what causes the problem with keratoconus. There are a number of associated problems, most typically allergy with keratoconus, but the one important thing to know as a keratoconic patient is not to rub your eyes. You can see in the pictures up top and below that many patients rub their eyes quite hard. Indeed, you can see on this MRI on the right side, this cornea can be really squeezed in. And what you can imagine is that it further distorts the collagen girders that support the cornea and can exacerbate keratoconus. So one take-home message is don't rub your eyes if you have keratoconus. There are 3 clinical goals in keratoconus management. Number 1, keratoconus is a progressive disease. It tends to get worse as time goes on. Just like if you have a thin tire that's bulging out, worsening generally occurs over time. Our second goal is to improve the corneal surface optics or corneal topography. And then finally, and of course importantly, is to improve your vision. And the types of things that we do evolve depending on your age. Early on, we want to stop progression and assure best vision. As one gets older, we can start to correct corneal curvature. After that, sometimes the lens or cataract becomes a consideration, and we need to attend to those. So there are different options that we bring to an individual patient with keratoconus, depending on the degree of keratoconus and where they are in life. Number one, and most importantly to start, is to stop the progression of keratoconus. KC is a progressive disease, and as it progresses, you can lose vision because of light scatter, but also because of progressive scarring and thinning. Fortunately, corneal cross-linking has been approved by the FDA, and this is a uniquely important addition to our keratoconic armamentarium. Collagen cross-linking strengthens the cornea. It uses the combination of riboflavin, which is vitamin B2. It's called a photoactive flavonoid. When it is exposed to ultraviolet light at a specific wavelength, it causes a reaction within the cornea that causes linkages. You could think of these linkages as being similar to adding extra girders and extra wires to a bridge to make the bridge stronger. So cross-linking makes the cornea stronger and therefore limits progression of the disease. This is the procedure in short. In the standard FDA procedure, a sponge is used to loosen the surface cells. The cells are then removed, and riboflavin drops are administered for a half an hour so they soak into the cornea. You can see on number 3 that we then check the cornea to make sure that the riboflavin, which is green in this picture, has completely saturated. You then go under the ultraviolet light, typically for 30 minutes, and this causes the cross-linking reaction. Afterwards, a bandage contact lens is placed to promote healing and comfort, and antibiotic and anti-inflammatory drops are given. Now, what is cross-linking for? Cross-linking is not to improve your vision. That is something that's misunderstood by many of our patients. Rather, cross-linking is to prevent further loss of your vision. Early on, the vision will be reduced somewhat as the initial healing occurs. There may be a slight haze to the vision, and this tends to resolve itself over the first several months, upwards of a year. Contact lenses can be resumed in a month, and although cross-linking works well over 92% of the time, you should still continue to see your eye doctor to make sure that there is no progression as the years go on. The US pivotal cross-linking trials were begun in 2008. I had the privilege to be medical monitor of those trials, and that led to FDA approval of cross-linking in 2016. Approval was for the Glaukos system, and it was specifically for the indications of progressive keratoconus, so keratoconus that's getting worse, post-refractive corneal ectasia, which is a keratoconic variant in patients who have had LASIK. It's for patients 14 years of age to 65 years old, and it is a standard procedure where we remove the epithelium. Well, what are the results? What we specifically looked at in the study was the height of the keratoconic cone. What did we find? We found that the height of the keratoconic cone actually improved by 1.6 diopters. So out of the, let's say, 50 diopters, there was an actual improvement over time. If we look at the control group who did not receive cross-linking, they worsened by 1 diopter. So there was actually a very substantial difference between patients treated with cross-linking and those who were not treated with cross-linking. A similar difference in patients with the corneal ectasia, but that's a little less robust than for patients with strictly keratoconus. We asked patients, how does your vision seem afterwards? Night driving, glare, halo, starburst, these are many subjective complaints that keratoconic patients can have, and most of these improved significantly. Generally, there is about a 1 line when you're reading the chart improvement after cross-linking, but again, keep in mind, our goal is not improvement in vision. Our goal is to keep your cornea nice and stable. And indeed, as you see here, we have followed our FDA patients now for 10 years, and for the great number of patients, about 94%, the keratoconus has been stable after 1 cross-linking procedure. Ectasia patients show a little more progression, so they need to be followed somewhat more closely. But in general, over 90% of patients with cross-linking are stable over a 10-year period. And if needed, cross-linking can be repeated. Now, there have been a number of cross-linking innovations over the years. I won't go through them all, but one thing that people talk about a lot is transepithelial or epi-on cross-linking. In that, we do not remove the surface cells. Remember, the surface cells are like the tiles on the floor and they need to grow back. If you don't remove the surface cells, likely we'd have a faster recovery, more comfort, potentially less wound healing effects and things like that. But the challenges are it may not be as effective. It may be more difficult for the ultraviolet rays to absorb, and there also may be more difficulty with oxygen reactions. But we've done a number of studies looking at the transepithelial technique. And we did find that vision remained stable, that the height of the cone decreased a bit, here by about 1/2 a diopter, and this is compared to the 1.5 diopters we see with the standard procedure. We have also participated in a phase 3 study by Glaukos for FDA approval of a methodology of a transepithelial epi-on technique. This is used a different riboflavin formulation. It uses goggles that transmit more oxygen to the surface, and it appears to be working, but we are still analyzing the data. And currently, we are starting a clinical trial, again with the Glaukos company, that looks at a laser diode cross-linking, which uses a very small, rapid spot of ultraviolet light with the goal of getting an enhanced cross-linking effect without the need to remove the epithelium. Now, we have a number of other ongoing trials at the CLEI Center for Keratoconus. We are looking at different types of riboflavin solutions, some that might work better, we hope, than others. Again, we're investigating the transepithelial epi-on technique using a number of different systems. And we are also looking at what's called accelerated cross-linking. That is cross-linking that is done in less than 30 minutes, combined with what we call topography-guided PRK. So what we do is we take the corneal topography, we are able to actually put that into the laser system that simply removes the area around the cone, and we can treat that area in and of itself with the cross-linking and have seen some excellent results. So with that, I'm going to turn the podium over to Dr. Greenstein, who's going to discuss new surgical innovations and new topography-guided innovations to improve the corneal contour and vision after keratoconus. Thanks very much.
Okay, so thank you, Dr. Hersh. So the next portion of tonight's talk, we're going to focus in on improving corneal topography. And as Dr. Hersh went over before, the first and most important thing when it comes to taking care of keratoconus is to stop the progression of the disease. And we have new and exciting ways of doing cross-linking, which hopefully will help with healing and also give us even better and more customized results. And we have new ways and exciting ways that we can also improve corneal curvature. And that really prepares the cornea for the ultimate goal, which is vision correction. So for the most part, I'm going to focus on how we improve corneal topography and corneal curvature, with then a little bit of touch at the end on how we are improving patients' vision surgically as well. So tonight I'm going to focus on 3 modalities that we use to improve corneal curvature, and they all work somewhat differently, and we use them sometimes in combination, and we use them for different reasons. Topography-guided PRK is using the laser to ablate the cornea and to reshape the cornea, and this does remove a little bit of corneal tissue to do this procedure. The CTAC procedure, which is the newest corneal topography improving surgery, is actually an additive procedure. So we're actually adding corneal tissue to the cornea. And of course, corneal transplant replaces the corneal tissue. So topography-guided PRK was, topography-guided LASIK actually was initially FDA approved in 2016. And the way that topography-guided ablations work in general is that we take imaging, we take topography, which are these ring images that you see on the right, and we generate a map of your cornea, which we then upload to the laser. The laser has a customized software, which then determines where the cornea needs to be flattened and where the cornea needs to be steepened. And so what you see on the bottom right is a map that's developed in combination with what the doctor and surgeon chooses to put in and what the laser would like to do in terms of reshaping the cornea. And you get a very customized ablation, which changes the curvature of the cornea. And this was originally designed to enhance LASIK corrections, but over time has been adapted off-label, but has been adapted to treat very, very effectively the irregularity of the keratoconic cornea. And so this is an example of a case where we used topography-guided PRK to treat the cornea. And again, on the picture on the right, you can see the pattern that the laser has developed, which is trying to flatten in the purple area in the center, right where the steep portion of the cone is, and also a little bit in the periphery to balance the cornea out. And you can see that when the laser does this correction, you end up with the precise flattening in the steep areas of the cornea, which you can see with the highlighted in green at the top right. And if you look at the maps in the bottom right, you can really see how profound the effect is with the topography-guided laser. So the picture on the bottom left shows a very typical keratoconic topography, which is red and pink at the bottom. That's the steep area of the cornea, where the cornea is bulging out. And then a flatter area at the top, which is green and then blue. And all the way to the right on the difference map, you can see that when the laser has ablated right over the steep area, it creates a green center and a very regular center of the cornea around the pupil. And this can lead to some very profound and significant visual improvement. As we'll discuss a little bit later, this can also be used to prepare a cornea for some vision correction procedures like an ICL or cataract surgery. So it has been a very, very useful tool for correcting keratoconic patients. Now, one thing to note in topography-guided laser correction is that we are removing a small amount of corneal tissue. So we do try to remove as little as possible. The cornea does have to be thick enough to be able to have spare tissue to remove. And you must have cross-linking done with topography-guided PRK to ensure that the cornea is not only reshaped, but also stiffened in the same process. And sometimes that'll be done before, as Dr. Hersh said, sometimes that'll be done simultaneously, and there are certain cases it might be done after as well. And an important area where we have used topography-guided PRK is to improve our outcomes from intacts. So many of our patients had intacts placed over the years, and as we published in the past, we saw about a 2-line improvement in uncorrected vision when we placed intacts on average, and just over a line of glasses visual improvement when we placed intacts on average. But for some patients, that improvement was either not enough or they didn't experience the average improvement. So if we look at the case on the left here, the leftmost picture is the patient's cornea after their intacts placement. So the cornea did become flatter, but you can see there's still a reasonable amount of red and pink areas in the center of the cornea, which has created a still halo and not a fully correctable vision for this patient. So the patient's vision after intacts was placed was about 2200 without glasses. It corrected to 2040 with a glasses prescription, and about 2025 when a contact lens was placed, a rigid contact lens was placed over the intact segment. Well, for this patient, we were able to perform topography-guided laser over their intact segments. Again, seeing that very customized flattening in the center. And what you see in the center map is the after topography-guided PRK image, which again is very green in the center, very regular in the center area. And this patient had 20/25 uncorrected vision after that enhancement was done. So again, this has become a very strong procedure in patients who have had no surgery, but also to help us improve our results from previous intact surgery as well. Now, really one of the most exciting areas that has changed keratoconus management is customized tissue inlays. And one of the things that has allowed us to customize inlays is tissue sterilization. So we are able to take corneal tissue, which is donated, and place it through an irradiation process, which removes the cell structure from the cornea, leaving the collagen lamellae, those pancakes that Dr. Hersh had talked about that make up the cornea. And by removing the cell structure, we're really removing a lot of the immune reaction that patients may have to the corneal tissue, and limiting, hopefully, really any rejection of this type of corneal tissue. In addition, the tissue is actually shelf stable. So once it goes through a gamma radiation process, it can stay on a shelf for up to 2 years, and it can even be stored at room temperature. But the real advantage is that when we have this tissue, we can then shape it into whatever shape we want, which can be customized around an individual cornea. So on the bottom right, you can see a corneal inlay that has been shaped with the femtosecond laser, and that is shaped specifically for a patient's cornea. And we're really excited because CTAC, corneal tissue addition keratoplasty, is actually the featured article on this month's Journal of Cataract and Refractive Surgery. And what you can see over time is that with the CTAC procedure, which we first started in 2016, we've really been able to customize the shapes of these inlays so that we can get really, really profound visual improvement results. One of the amazing things about the inlay is that if you look at the picture on the bottom right, as time goes on, you can barely see the inlay in the patient's cornea. So you can kind of see the bare outline of the inlay that was placed, and that's how natural the inlay looks in the cornea. These pictures really show why CTAC excites us so much, and we can use it in mild cases of keratoconus, we can use it in moderate cases of keratoconus, and we can use it in severe cases of keratoconus, and they all end up with a very symmetric result. So at the top, where we have a more severe case, a very steep, large red and pink area, we can induce a significant amount of flattening and really shrink that area. So afterwards, you have a very small, regular appearance of the cornea in the center. And then all the way at the bottom, in a much more mild case of keratoconus, we can customize the flattening so that we get the same result in both a severe and mild keratoconus patient. And the results we published have really been nothing short of amazing. We saw 6 lines of uncorrected visual improvement in patients who had CTAC segments placed. So this meant that patients were going from vision that was just better than about 2400, so really just seeing the big E on the chart, to vision of 2080. And in their glasses, patients were going from a vision of 2090, so really not a functional vision. To give some idea, 2040 vision is around a driving acceptable level of vision, to getting an average vision of almost 2040 in glasses. And this was primarily on patients with very severe keratoconus, which we started treating earlier on. So this kind of visual improvement has really not been seen in other types of keratoconus procedures. And when we look at how it compares to what we have available, we know that cross-linking is not really a vision correction procedure. As Dr. Hersh talked about, it's a stability procedure. And we see that sort of on average, you get a little bit close to about a line of visual correction, a little less without glasses, and about a line with glasses. And as we discussed before, with Intacs, we were seeing about 2 lines of correction with uncorrected vision, and maybe about 1 line in glasses. With PRK, which we have found to be even with even greater results, we see about 4 lines of uncorrected vision and still about a line of vision correction in glasses. Sometimes with Intacs combined with PRK, we're seeing a little bit more, but nothing has really improved vision the way that CTAC has, with 6 lines of uncorrected vision and 4 lines of corrected vision in glasses, with almost double the amount of flattening that we were seeing with Intacs and PRK combined. So CTAC has been really a game changer. There's still cases where it's not the right procedure for you, and that is where a corneal transplant comes into play. And even in the cases of corneal transplant, we have had significant improvements in the way that we do the transplant procedure. So one of the things that I wanted to highlight in the last remaining minutes for this portion of the talk is, one thing that we have seen is that with cross-linking, the need for corneal transplant as a whole has been reduced. This was a study done with the Netherlands, which saw a 25% reduction in corneal transplants over a 3-year period when cross-linking was introduced. And even in the US data, we have seen that the primary indication for transplants, which used to be keratoconus, has actually now become a repeat transplant since 2016, which is also the time that cross-linking was introduced. And scleral lens technology, as Dr. Gelles is going to talk about in just a minute or so, has become so good, and with the ability to fit lenses over much more severe corneas than we ever did in the past, and even around scarring in ways that we never did in the past, that the need for corneal transplant has really diminished. And the primary reason that we really do corneal transplant now is corneal scarring. If there is too much scarring in the visual axis around the pupil, where a contact lens, corneal inlay, topography-guided laser is not going to clear the opacity, it's not going to clear the blurriness of the vision, then a corneal transplant is needed. And one of the advancements in corneal transplant is using the femtosecond laser to assist in doing the transplants. Originally, the main advantage of using the laser was it allowed us to create some different patterns in our cuts, things like the zigzag or top hat or mushroom that you see, which allowed for more precise placement of the corneal tissue with the goal of limiting astigmatism and a need for contact lens correction after the corneal transplant was completed. And now we actually have what's called OCT guidance. We're able to use pictures that we take intra-op, we take them during the procedure to then mark where we want the laser to make the cuts in the cornea. This allows us to go down to very precise depths and has really enhanced our ability to do partial transplants. So with keratoconus, where the scarring and the disease is usually in the front portion of the cornea, and we can usually preserve the back portion of the cornea, the ability to use the laser and guide our cuts has really improved our ability and reproducibility of being able to do these partial procedures. That has a huge advantage for healing and also for visual recovery. And most importantly, the chances of rejection and failure of these grafts is much less over time. So you can expect the partial transplants to last a much longer time than the full transplants do. And finally, I'm going to very quickly just touch on the surgical improvement of vision. So once we've stabilized the cornea with cross-linking, we've improved curvature, whether it be with PRK, corneal inlays, transplant. The main thing we want to accomplish is visual correction. And glasses, contact lenses are, of course, going to be one of the main modalities that we improve vision. Dr. Gelles will touch on that next. But one place we've seen a real change is that because we have the ability to improve the curvature of the cornea, we are then able to use some of our general refractive tools, some of the things that we use for patients who don't have keratoconus, to actually improve vision. So here's a case where we were able to get really good topographic, really good corneal curvature correction with topography guided PRK. Again, in the top, you're seeing those reproducible ablations where the red, pink areas get shrunk and pushed out into the periphery of the cornea, leaving the center portion very green and very regular. And when that happens, then we can then use a procedure like the ICL, which is an implantable contact lens, to improve the remaining prescription. So in this case, this patient couldn't see the chart without their glasses. Even with a glasses correction, they only really corrected to 20/50. But when we fixed their corneal topography, stabilized their cornea, and then placed an implantable contact lens, their uncorrected vision, their vision without glasses, improved to 20/25, really almost 20/20. And similarly, and this is a really important time to consider the use of topography improving surgery, we can use this technology before cataract surgery. And we've had a lot of success with patients who have worn hard contact lenses for many years, improving their topography with corneal inlays or PRK, so that we can then, when we do their cataract surgery, choose a lens which is going to improve their vision. And the patient that you see here was seeing 2100 with no correction, 20/70 in their contact lens, partially from their cataract, but partially from their keratoconus. And when the keratoconus underwent topography guided PRK for reshaping, and then cataract surgery, their vision also improved to almost 20/20, 20/25 plus 2. So these are obviously great cases, and not everybody is a candidate to have these procedures done in totality. But with all of what we have available to us nowadays, there is so much opportunity to improve your vision surgically, and then still improve it even more with modern contact lenses, which Dr. Gelles will talk about now.
Perfect. Thank you, Dr. Greenstein. Let me go ahead and get this one going here. Just going to make a quick. There we go. We see in my screen?
Yep, that looks good. But yeah, there you go.
Very good. Perfect. Awesome. So thank you very much, Dr. Greenstein. So we'll start to get into, contact lenses for keratoconus. So when we look at contact lenses, these are really an option no matter what age you are. And these can be beneficial for visual correction. The important thing to note on this is that specialty contact lenses are really the mainstay of vision for an individual with keratoconus. However, we can't neglect the importance of visual correction for the rest of the time, when you're not wearing your contact lenses, so in glasses and without. So that's why it's so important to look at this as a comprehensive treatment for keratoconus. We want an individual to use these lenses to make their vision as good as possible. And the way that these lenses work to do that is by masking the irregular anterior shape of the cornea. This allows the light to better focus in the back of the eye. Many individuals thought that these lenses are there to smash the cornea or push the cornea into a certain shape, but that couldn't be further from the truth. When we have a lens that's pressing on the cornea, it can actually damage the cornea. So the idea here is to create a lens that just simply masks the irregular cornea underneath it to help to sharpen those light rays coming in so that they all focus at the same spot and reduce the amount of distortion that you see in the vision. So there's a variety of different options in lenses here. And the goal with all of these lenses, whether they're soft or rigid, is to improve the vision, give you good comfort while maintaining the ocular health. The important thing to note with these lenses is that they are for visual improvement only. There's no effect on progression. It used to be a thought back in the day that if we fit a lens a certain way, we can stop the progression of keratoconus. That is not true. The only thing that stops the progression of keratoconus is cross-linking. So consider that contact lenses, if you're only getting contact lenses, you are only helping the vision. You are not treating the disease. So it's a very important distinction that we really need to highlight. Now, when do we use each one of these lenses? You know, we can look at all the different types of lenses there. There's standard soft lenses, there's custom soft lenses, corneal rigid gas permeable lenses, hybrid lenses, piggyback lenses where we use a soft lens with a rigid lens on top of it, and scleral lenses. Well, we wanted to answer this question, so we looked at 770 eyes in our clinic from about a 30-month period of time and looked at the ones that were successful and the ones that had failed. And we looked at the characteristics of their cornea to determine who might go into what lens. And what we find is that individuals with very mild disease generally do very well with standard soft lenses. But as we start to get into the mild to moderate disease levels, we start to see that individuals are needing rigid gas permeable lenses, hybrid lenses, and custom soft lenses. As we get into the advanced to severe category, that's where we start getting into scleral lenses and piggyback lenses. And this is where we start to see that we have this continuum of contact lenses. Now, many times we get asked by patients, which one of these lenses is the best? Well, what we found in this review was that there was no such thing as a universal best lens. Any one of these lenses can fail, but any one of these lenses can be successful. What we found, though, that was the main reason why people failed in a certain design was because their keratoconus was too severe for that type of lens. So if we had somebody who was, you know, on this severe area and we had them fit with a standard soft lens, they were unsuccessful. So that was where we kind of saw that, you know, these lenses had certain characteristics that they worked for on certain corneas to work really well. So again, we went back to that same thing. What lens is the best? It's the one that improves your vision with good comfort while maintaining the ocular health. The main issues that happen when a lens is too steep is that the lens wants to flick off of the eye. So for those who have worn soft lenses or corneal gas permeable lenses who have more advanced levels of keratoconus, you're very familiar with that spontaneous, you know, launching of the lens off of the eye, or you blink the lens out. And that happens because the cornea is just too steep for the design of the lens that's being used. The other thing that can happen with corneal lenses is if they're, you know, the cornea is too steep for that type of lens, the lens can rub on the cornea, which leads to corneal abrasions and discomfort. And over time, that can lead to scarring of the cornea, which can reduce the ability to correct your vision. Now, what we found was we did another subset study of these eyes, and we looked at 48 eyes that were successful in soft lenses, or rather that were attempted to be fit in soft lenses that had a history of rigid lens failure, meaning that they had failed either a gas permeable lens, a hybrid lens, even a scleral lens, and sometimes even piggyback systems. And what we found was that about 75% of these eyes that had failed rigid lenses could actually be successful in a custom soft lens. So, you know, what we need to look at is, you know, what is a reason for failure And it really comes down to finding somebody who has all of the options available so that we can find the right solution for you. There's no such thing as a one size fits all. And if you've been told previously that a rigid lens is your only option and you've had a difficult time with rigid lenses, it's possible that custom soft lenses might actually be an answer for you. The reason why this works compared to like a standard soft lenses is we can really change the parameters of these lenses, and this extra thickness helps to mask the cornea. You can see this is the same eye with a standard lens on the left eye and the custom soft lens on the right eye. And you can see because of that added thickness, we get much more of a dome shape than what we would get otherwise with the peak shape that we're seeing from the standard soft lens. So what about, scleral lenses or other things like that, right? Many individuals may have problems with scleral lenses because the white of their eye has irregularities or has a very, very complex shape to it. And we can struggle with scleral lenses for those individuals. Well, there are newer ways to design lenses, and these methods kind of started out being a method that you can use in scleral lenses, but this has actually now been applied to corneal gas permeable lenses as well. And this is where we take a scan of the eye and we output the data, and we can create three-dimensional models of the eye. Or we can take an impression of the eye and 3D scan the impression to, again, create a digital model of the eye, and then we can design a lens to that model so that it fits your eye better. So you can see these very complex shapes that are shown here with these undulations. These are there to mirror the corneal or ocular surface shape so that we can get a better performing lens for you, a lens that fits the eye much more appropriately and thus much more comfortably. Now, what about for those individuals who struggle with vision? We know that we use scleral lenses a lot for individuals who have severe levels of keratoconus. Like Dr. Greenstein was saying, we can use scleral lenses in those extremely severe cases, but in many of those individuals, the vision may still be poor or not to a level of visual acuity that we really want them at. And that's where wavefront guided scleral lenses come into play. Now, one of the things that we need to talk about is quality of vision. What keratoconus really does is decrease the quality of vision. So when we look at the vision here, what we're seeing is an E for somebody who has a perfect normal cornea. Now, down below it are various levels of keratoconus corneas being represented. And you can see that though you can still tell it's an E, the quality of that vision is still very poor with keratoconus versus somebody who has perfect optics, right? So what we're doing with wavefront guided optics is we're trying to create an improvement in the quality of the vision. So how do we do that? The concept is very similar to noise canceling headphones, where we look at the sound wave coming into the speaker, and then we create an equal and opposite sound wave to cancel it out. We're using the same concept, but what we're doing is we're measuring the light rays and how they scatter going into the eye. And what we do is we create an interference pattern that's ground or surfaced into the contact lens in a custom way to create an equal and opposite effect so that it cancels out and improves the vision so that we end up seeing a much clearer image. So the way that this works is we put a scleral lens on that has a dot pattern on it. We take a measurement over the top of it, and then what we do is we take that information and we inverse that, and we manufacture that onto the contact lens surface. That way, when you wear the lens, the aberrations are canceled out, and thus the quality of the vision is improved. You can see that we have on this map a more even profile than what we saw previously, and that's what improves the vision. So what we can see is a comparison of an individual here. They had a traditional scleral lens with normal optics on it on the left, and then the wavefront guided optics on the right, and you can see the improvement in the visual acuity here in the point spread functions and in the chart simulations here. But what we can also see is if we simulate it into a real world situation like driving. And you can see how much clearer the vision is on the wavefront guided scleral lens side than the traditional scleral lens side. One of the case studies that we had, this was a cardiothoracic surgery fellow that we had as a patient, came in with visual acuity of being kind of 20/30 minus. So his keratoconus, he actually had pretty decent vision. And we were going, oh, okay, well, we'll add a lens on and we'll just improve your vision. With a traditional scleral lens, he was still 20/30. When we added the wavefront guided optics, we were able to improve his vision by about 2 lines from 20/30 to 20/20, and we reduced the amount of distortion, that decreased quality of vision. We improved the quality of his vision by about 65% in each eye. So a big improvement for him. Now we've done this now on several hundred eyes, and when we look at this, on average, what we see is people gain about 1 line or more of visual acuity, and we see on average about a 50% reduction in their blurriness of their vision. We reduce that distortion there. And when we subjectively ask individuals, which lens do you prefer, the standard lens or the wavefront guided lens, the vast majority of them prefer the wavefront guided optics because the visual acuity is just more crisp. You have more or an improved quality of vision. Now, I want to talk a little bit, just very briefly, about complications from contact lens overwear. When we have contact lenses that are ill-fitting, or we're just overwearing our lenses for more hours than we should, we can have complications that arise. We can have abrasions that lead to infections, and those can be extremely painful. But over the long term, in lenses that aren't really performing well, we can have abnormal blood vessel growth into the cornea and even scar formation in the cornea that will reduce our visual outcomes. So it's important, no matter what lens that you have, to follow up frequently to reduce your risk of complication. But this is also why the keratoconus 1, 2, 3 is so important. Many individuals with keratoconus, because they're relying on their contact lenses to give them their best possible vision, and they may not have functional vision in their glasses, when they're experiencing problems like pain or light sensitivity with their lenses, they continue to wear the lens because their vision isn't functional. And that's why it's so important to take on this keratoconus 1, 2, 3 approach, so that we're comprehensively caring for all of your visual needs, whether it's without contact lenses or glasses, with glasses, or with contact lenses. So when we look at this, again, the most important portion of this is stopping the progression of the disease so you don't continuously get worse, the ability then to improve topography for some individuals, and then our final step of improving vision. So with that, we want to look at this as being collaborative, comprehensive correction for an individual, whether you're wearing contact lenses, glasses, or being without them. So with that, we'll go ahead and stop the, or rather go ahead and start the Q&A here. This is our information if you want to get in touch with us. You can email us at info@visioninstitute.com. Or visit the website at visioninstitute.com. So with that, Gloria, I'm sure we have some questions that we want to have answered.
All right. Well, first of all, thank you, Dr. Hersh, Dr. Greenstein, and Dr. Gelles. That was an incredible comprehensive review of keratoconus, progression, treatment, cross-linking, surgical options, CTAC, which is really amazing, and the role of specialty contact lenses. Thank you for all of your sessions. So we have a couple minutes to answer a few questions. We won't be able to get to them all, but let's start with questions on cross-linking. So maybe Dr. Hersh can take this one. At what age is cross-linking available, and are there any risks associated with the age of a patient?
Cross-linking with FDA approval is 14 years old. However, I think that the importance of identifying keratoconus at the youngest possible age can't be overstated. So if I had a child even less than 14 years old with keratoconus, I would definitely consider cross-linking. The earlier you get keratoconus, the more rapidly progressive it tends to be. So the important thing for kids is to pick it up early and to treat it as soon as you can once it is picked up. So if there's any keratoconus in the family, so to speak, or other indications of poor vision, I would consult with the eye doctor and make sure that we're not dealing with keratoconus.
Thank you. And on a similar note, what age is progression of keratoconus unlikely in what you've seen clinically, what you know from your research? Is there an age where you're totally safe?
There is not an exact age, but from the point of view of keratoconus, the older, the better. I would say things start slowing down as you get older. Again, kids who get it earlier on tend to progress more rapidly and continue to progress. Those who have discovered their keratoconus later on in life tend not to progress as rapidly and stabilize earlier. I would say 35 years of age, give or take, is the time where we start to see a much diminished progression of KC. But even at that age, it should be followed carefully. One does not necessarily need cross-linking, but it should be followed with serial corneal topographies to make sure that there is no change.
Got it.
I would just add to one thing to that is if you've had LASIK done, so ectasia or finding keratoconus after LASIK really does change that that dynamic. And I think we have seen that there is no age where if you've had LASIK done in the past and have developed ectasia after LASIK, that we can ensure stability without doing cross-linking.
Correct.
Thank you. Very good point. So this one, Dr. Greenstein, first of all, congratulations on your team for all the work you're doing with CTAC. What an incredible life-altering process for these keratoconus patients. I have actually a question. How is this procedure CTAC like CARES, the corneal allogeneic intrastromal ring segments? Is it similar or different from that procedure?
So the CTAC procedure it's similar in the sense that it is using a corneal tissue that is then cut and placed in channels of the cornea. Where it really shines is in its customization. So the aspect of CTAC, which is very different, is that we are able to take corneal topographies, we're able to take maps of individual corneas and then develop a segment that is then cut specifically to a patient's cornea. And that customization, we think, has led to some of the really striking results that we've seen. In addition, all CTAC tissue is cut on a femtosecond laser. So it's all prepared to very precise specifications from the topography maps that are sent. So you're getting a very precisely prepared tissue on a femto laser that is prepared for your specific cornea.
Yeah,
Very neat.
I'd like to add one quick thing to that too, which is that the CARES was made to mimic Intacs, essentially just made of a tissue, whereas these are much larger segments of tissue. This is a lamellar keratoplasty, whereas CARES is really a tissue ring segment.
Got it. Thank you for the clarification. So someone also asked, can CTAC or Intacs be done after a person has had a cornea transplant?
Generally not. I think usually the reason for needing adjustment in your corneal transplant is going to be somewhat different than why Intacs or CTAC works. There are plenty of things we can do, one of them being topography-guided laser, or different types of incisions or procedures to adjust astigmatism in a transplant. CTEC and Intex is not the go-to for that.
Got it. So one question for Dr. Gelles. What is the steepest Kmax that you have successfully fit with contact or maybe scleral lenses? And how wide was the diameter?
Yeah, so I guess on that, I think we fit a 120 diopter, somewhere around there, 120 diopter cone. And the largest contact lens that I have built for a patient has been a 24 millimeter lens. You know, and it's variable based on who would get that. The individual who had the 24 millimeter lens was actually not the individual who had the 120 diopter Kmax. So it's variable. Each individual, you know, has various different nuances that would dictate what size of lens you're going to pick for them, and you know, the parameters around it. It's really a customized, you know, method that goes along with it. But in general, that's kind of the fun facts. Yeah, we can fit some very, very steep and advanced corneas and get good success for them.
You know, I really like in your section how you said that one size doesn't fit all, and I agree with you completely. And every patient's always asking, I want the best lens. Give me the best lens. Like, what is the best? And ultimately, it depends on the person, their cornea shape, their stage of keratoconus, whether they have scarring, higher order aberrations. So I think it's really important that, you know, patients recognize that what works for their friend or the person in that Facebook group may not work for them, and to really work with their, you know, eye care provider to individualize and optimize treatment for them. And I really like how, you know, you've stressed that the contact lenses don't change the disease itself. So treatment of the disease is not the same as vision correction. So I think we've hammered that across as well. And hopefully our patients will understand that you can't just get a contact and see well. You have to remember we have to treat the keratoconus at the earliest stage possible as well. So with that, do we have another slide for our next webinar on here? If not, it's okay.
There we go.
Awesome.
We're up.
So thank you everybody for attending this webinar. It's bittersweet for me as this is my last webinar that I'll be moderating. But our next webinar will be on September 12th on the topic of what is midday fogging and how to remedy it by Dr. Maria Walker. And our new moderator for the National Keratoconus Foundation will be Dr. Karen Lee. So thank you everyone for attending. Thank you to our expert speakers tonight, Dr. Hersh, Dr. Greenstein, and Dr. Gelles. We appreciate your time and all the education that you provided to our audience today, and to everyone who will be watching the recordings later on. And have a great day, everyone. Thank you.
Thank you very much.
Bye, thank you.
Good night, everyone.
Bye.